I just thought I'd do a bit of an overview, just different options, what we do overall, and just a brief summary of it. So hopefully that'll be helpful. All right, so I wanted to just see, I have a couple of little questions just to see where everyone's at and see what you know, and I think it'll be a bit of fun just to go over it. Okay, so before that, most of you I think are patients here, right? How many of you are CLL patients? Most of you? Okay, perfect, all right. So we'll just go through these really quickly, see what we know, and then I'll go over some of them in more detail. So which of these do you think is not an option that we have for CLL right now? So is not. So who thinks chemotherapy is not an option? Okay. What about bone marrow transplant? Immunotherapy? Hormone therapy? Yeah. Okay. And biologic therapy? All right. Okay. So we'll come back to it.
What is biologic therapy?
I'll get into that. Okay, so which of these is a type of biologic therapy that we use in CLL? There's other names for it, molecular biologics, some of us call them, but anyway. Ibrutinib? Okay, imatinib? Okay, Revlimid? And what about chlorambucil? Okay, yes, all right. Everyone's too smart. I should just be done now. I'm done. Okay, so which of the following is a side effect of ibrutinib? So we have atrial fibrillation or irregular bleeding. Okay. And that's the end. Okay. All right, so we're gonna just go over, we'll just do an overview of things. So I won't get into too much detail, but I wanted to kind of tell you a bit about all the different treatment options we have, what we would do before we treat you, what things we would consider, and then we'll talk about the watch and wait, which a lot of you probably are on, and then different treatment options. Some of them are not really available prime time, like the CAR Ts and all of that. You heard a bit about it already, but the more regular common therapies we'll talk about, and then the complications of CLL that you may have come across, and then drug coverage in Ontario, a little bit about that. It's sort of a moving target, and we often don't know what's covered or what's not. It changes every day, but I'll tell you what I do know, and then treatments that are upcoming. All right, so I think you already heard a bit about the background of CLL, but just a little bit of info. It's a fairly common lymphoid cancer. So in your blood, we have myeloid cells and lymphoid cells. And myeloid would be kind of your red blood cells, platelets, etc. And then lymphoid cells are white blood cells, and lymphocytes would fall under those, and that's how you get CLL with the lymphocytes. So it's a little bit more male predominant, but certainly females get it too. We don't really know why you get it. And treatment generally has advanced quite a bit over the years. So back in the day, it was probably just chemotherapy, maybe not even chlorambucil, et cetera. But now we have all these newer therapies that target certain enzymes, biologic ones. So, all right, and a lot of treatments are now oral, which is great. Okay, so the first big thing with CLL is there's probably a lot of you that have it but are not being treated, which is actually quite common. So we don't need to treat it unless it causes problems, essentially. So I listed some of them here, but there is certain criteria that we follow as hematologists is when to treat someone. So generally, if your lymphocyte count is really high, which it will be often, doesn't necessarily mean you need to be treated, but we usually look at kind of how fast it's rising or doubling. So we often say if it doubles in less than 6 months, sometimes a year, but kind of that 6 to 12 month range, if it's doubling, then we worry that maybe it needs to be treated. The other thing would be symptoms. So we call it B symptoms, so that would be like getting fevers, weight loss, night sweats, and then just really fatigued, so things like that. The other thing would be having big organs, like a big spleen, big lymph nodes showing up, and it's causing you problems. A lot of people have lymph nodes that swell up, but we don't necessarily worry unless it's sort of causing you issues or getting really big, causing you problems in your day-to-day. So those are sort of the main reasons we would treat. There's other more subtle things, but generally when it's causing you problems, we would go from watch and wait to actually considering treatment. So it's kind of an ongoing. And it doesn't have to be overnight either. Sometimes we watch for a few months and then we treat after, so it depends. All right, so if you're deciding to treat, then there's a few things that we do right off the bat just to know that, okay, you're gonna be treated, what do we need to know before we start? So there's sort of disease issues and patient issues. So for the disease, we do this thing called molecular testing. So that's where we want to find out what kind of genetics you have, because that could affect the treatment that we give you. Symptoms, so like I mentioned before, so the B symptoms or getting tired or blood counts, etc. So then the patient itself, so things that affect you, so other medical problems that you may have, we look at. For example, cardiac disease, I think someone mentioned earlier. They had cardiac disease, and should they go on ibrutinib? So that's something we consider. Functional status, so how strong are you? How would you tolerate treatment? Could you go on chemo? Maybe you may not be strong enough to do that. And then preference is always important. So what do you prefer? If some people really don't want IV meds or injections, they really just want pills. So we try to take that into account, although it's not always possible. And then the biggest thing for us is, and for patients, is drug coverage. And I put it under patient because it also depends on your private insurance and all of that sometimes. And government, of course, but that's a big thing for treatment. Okay. So the problem with CLL these days, it's a good thing really, is that we have a lot of options, but the issue is that they're not all fit for certain patients. So it's not like a one size fits all, but there are options, which is great. So probably the most common initially is this watch and wait. So you get diagnosed with CLL, which I think you talked about earlier how that happens, but now we're going to say you're diagnosed with it. What do you do next is usually nothing initially. So we do all the initial testing and we say, okay, you have CLL, but if you're fine, you're not symptomatic, your blood counts are stable, let's say your lymphocyte count is 30 and it's staying around 30, then we don't have to do anything. So we just watch and wait. And usually that could mean seeing you every 3 months, every 6 months, depending on how stable you are. And then we just wait. So every time you see the doctor, they'll probably do a CBC, which is your complete blood count, check your lymphocyte count, and check a few other things, which we'll get into. And otherwise, we just wait. So every time you go, they'll ask you, do you have any symptoms? Check your blood counts. Is it doubling? Are you getting lumps or bumps? So those are the things we would monitor, and then we wait. So now we'll get into some of these options. So now let's say that you've started getting symptoms, or the counts are doubling and it's time to treat. So your hematologist decided to treat you. So there's various options, and then we'll talk about who gets what, but I'll go over the options in brief. So chemotherapy is the most well-known, of course, historically. So immunotherapy is a little bit different. It's still part of the chemo, but it's therapy that specifically targets certain receptors on the immune cells. So for example, the most common chemo that used to be used previously and is still used is something called FCR. Has anyone been on FCR? Yeah, okay. So it's fludarabine, cyclophosphamide, and rituximab. So the F and the C are true chemotherapy agents. The rituximab, it is sort of chemo, but it's considered immunotherapy because it specifically targets a receptor on the cell. And as a combination, we say chemotherapy, but as a combination, it's sort of chemoimmunotherapy. There's another one called chlorambucil and obinutuzumab. Anyone on that one? Yes, okay. So that's sometimes used for people that aren't as fit, maybe a little older, maybe a little less strong, maybe a bit better tolerated. The FCR tends to be a bit more toxic than the other ones, and by that I mean like side effects, infections, etc. So then sometimes they use this other one to give you a bit of a better experience. There's another one, we call it BR, bendamustine and rituximab, and that one is similar to the chlorambucil and obinutuzumab in that it's a little like sort of lighter than the FCR. So the FCR is kind of like really hitting it hard, and the other two are still good treatments, but they're a little less hard on you, I guess, for the most part. The way chemo works, the bottom line is that it kills cancer cells. So it's used for lung cancer, colon cancer, etc. Same with blood, and it kills the lymphocytes in various different ways. And we won't get into it. It's complicated how every single one has a different mechanism. But specifically for rituximab, I mentioned it basically binds to a receptor on the cell surface and then kills it. So the bottom line is you're killing the lymphocytes and hence treating the CLL. So side effects of chemo, it really depends on each medication, but generally things like nausea and vomiting are fairly common. You may or may not have it, but it can happen. The biggest thing is dropping your blood count. So the chemo doesn't always know what's good and what's bad. So it's going to kill all your blood cells and the CLL cells, but it may also kill some of your hemoglobin and your red blood cells, your white blood cells. So hence why when you go to the hematologist, they check your blood every time because it might be lower than expected, and then they may have to delay chemo, for example. So it drops your blood counts, and as a consequence of that, you could get infections. So that's why they tell you to go to emerge if you get a fever when you're on chemo. It's because of that reason, is that your blood counts are low. So with rituximab, maybe some of you experienced this when you had it, is that it can cause infusion reactions. So when it goes in your blood, you can get various things like fevers, rash, rigors, which is like chills. You just feel really unwell when it's going in because it's sort of a very foreign drug going into directly in your bloodstream. So your body sort of reacts weird initially, but then the second time you get it, it's somehow sometimes better, but it really depends. You can never predict. So sometimes we give you medication before to prevent that from happening, and it can be quite scary when it happens because it's like this side effect that's so pronounced, but it's really probably just the reaction to rituximab. All right, so the biologic therapy I mentioned, so really what I mean by that is when it's not really chemo because you're not just killing everything in sight. You're specifically targeting a certain molecule or protein and hence trying to be more specific to kill CLL. Essentially, that's kind of what it does. So ibrutinib, which you've talked about quite a bit, sounds like already, or Imbruvica is sort of the new drug, not so new anymore, but very commonly used in CLL. And it targets an enzyme called the Bruton's tyrosine kinase. And that enzyme is very much involved in CLL growing, essentially, and those cells dividing. So by hitting that enzyme, you kill the CLL cells. So that's the main one that we use. There is something called idelalisib, and it targets a different enzyme and similarly kills CLL. But you see how these ones are not just killing cells, they're specifically targeting an enzyme that is in the CLL cell and hence killing them. That was a bit more specific. And then venetoclax, which I heard you all talking about earlier, and it targets a certain enzyme as well, BCL2. So those are some of the newer, more targeted therapies. So biologic or targeted is another name for it. So side effects, these have side effects too. They can be actually just as toxic in some people as chemo, like it just depends. But ibrutinib has a lot of these cardiac effects, so like atrial fibrillation, where you get this irregular heart rhythm. You can get bleeding, and the reason that happens is we know that ibrutinib somehow affects the function of your platelets, and the platelets are the cells that cause blood clotting, so if they're not working, then you could get bleeding. Nausea, vomiting, diarrhea is sort of the blanket statement for every pill you ever take. They're going to tell you could get that. So we just always say it, but it depends on everyone, but it's up there. Fatigue, again, very non-specific, but it's possible. Idelalisib, is anyone on idelalisib? No? It's not very commonly used these days. Well, it can be used, but for some reason now, for a good reason, probably venetoclax is sort of taking over a little bit more, but idelalisib is another one that can cause some toxicity. So I listed it up there. We won't go into in too much detail, but liver, diarrhea, etc. And then venetoclax, the biggest toxicity with it that we see is something called tumor lysis syndrome. And what that is that you basically are killing all these cells so fast that you can release toxins into the blood because all these cells are dying, and those toxins can then, these toxins can affect your body, like your kidneys and all of that. So we call that tumor lysis, and that can happen with venetoclax. All right, so we'll get into this again, but ibrutinib is sort of the I guess you can call it, it's a big drug in CLL right now. We use it a lot. It's very well tolerated generally, and it's a good drug. But it's not available to everyone, unfortunately, but there is a specific mutation in CLL. It's called 17p deletion. Does anyone have that? Anyone heard of it? Yeah. So basically when I said initially when you get diagnosed with CLL, they do this genetic testing. And if you have this 17p deletion, it's basically, you have chromosomes 23 chromosomes, and 17 is the number of chromosome, and then P is the arm of the chromosome. So if you have a piece of genetic DNA deleted off that arm, which they test in a lab, then you're considered to have a bit of a higher risk CLL. So it means your CLL could be a bit more aggressive, it could grow faster, it could maybe, instead of doubling, in a couple years, it might be a lot faster. So in those patients, the government will cover, or they'll generally cover ibrutinib for you because trials have shown that they benefit. The second thing is another genetic test. It's called IgHV. So in CLL, you have these immunoglobulins or antibodies that the cell produces. And they basically molecularly test those antibodies and look for a mutation there. And it's called, so IgHV stands for immunoglobulin heavy chain. Immunoglobulin is an antibody, and a heavy chain is antibodies have heavy and light chains when you look at them sort of molecular, at that level, at a cell level. And if you're mutated there, it's actually a good thing. So if you're unmutated, it's a bad thing. It's more higher risk. So if you're unmutated IgHV or a 17p deletion, those two things, as hematologists we look for, then you probably would be able to go on ibrutinib a lot easier. Like it would be generally covered for you. We wouldn't have to go through the hassle of trying to get the government to cover it, et cetera. Generally, we can make a case for it. All right. So stem cell transplant is not done very often in CLL. It is an option, but it's certainly not, it's very rare. So it's for probably very high risk CLL that's kept relapsing. I've never seen anyone have a transplant for CLL myself, probably just because with all the new like ibrutinib and all this stuff now that are working much better. But today there's not much of a role for a transplant unless you really have relapsed many, many times and nothing else is working. And the reason someone might get a bone marrow transplant is if, again, they're really young and relapsing, if maybe a part of a trial, or really high risk disease, or, and we'll get into this later, is that CLL can sometimes transform to a more aggressive lymphoma. And if that happens, then you might be eligible for a transplant because now you're dealing with something totally different. And then you don't have CLL anymore. You did, but now it's transformed into something worse, so then they might consider the transplant. Okay, and then CAR T therapy. So again, like I heard you talking about it briefly before. I couldn't tell you exactly where trials are being done or offered. There are some underway. Certainly where I practice at Humber River Hospital, we don't do it there. It's more of probably downtown Toronto sort of thing. But I mention it because it's something that's up and coming. I just attended a myeloma talk the other day, and they're even using it in myeloma, multiple myeloma, which is another blood cancer. But so it's really in all hematologic cancers, they're trying to use it now. And the bottom line of this is that you take blood out of the patient with CLL, and then you take their T cells, which are their immune cells, and then you reprogram them to want to attack your cancer cells. So you reprogram them to make it so that when they're put back in you, they'll go attack your cancer cells or your CLL cells. So normally they wouldn't, because they're your own T cells, they wouldn't attack your own CLL cells, but you can reprogram so that when we put them back in you, they will attack your cancer and kill them. So it's a very promising therapy, but it's very much still new and coming down the pipeline. So radiation is another option. So again, not common, but it's usually only done for a very localized disease. So if you have CLL and it's only in one area, like maybe one lymph node, maybe you might be considered for radiation, but it's quite unlikely. It's a very case-by-case thing. But there's something called SLL. Has anyone heard of that? Small lymphocytic lymphoma. Yes, yeah. So it's kind of one disease, really. It's sort of two parts to one disease, because CLL it's just called chronic lymphocytic leukemia because it's in your blood. So whenever you say leukemia, that means like Leuk means white blood cell and emia means in your blood. So it's like circulating in your blood. But lymphoma is in lymph nodes. So CLL can be in your blood and in your lymph nodes. So if it's only in your lymph nodes, we call it SLL. And if it's only in your blood, we call it CLL. But if it's in both, then you may be called CLL/SLL, which is what a lot of people have, because it's kind of flowing everywhere. And so most people have it everywhere, and lymph nodes, blood. And so if you only had SLL, like just in your lymph nodes, maybe you might be considered for radiation, but again, it's quite rare. Most people are on pills and that kind of thing. And another reason for radiation is palliative treatment. So what that is there's a misconception with that word that it means end of life, and that's not always the case. Palliation is just treating your symptoms. So if you have symptoms from really big lymph nodes that are blocking, causing pain, or like trouble swallowing or something, a big lymph node in your neck, then they might radiate that to make it smaller, but it's uncommon generally. All right, and then finally, clinical trials. The general gist of a clinical trial is that you have CLL that we're not able to really treat with regular medications. It's relapsing, and they want to put you on a clinical trial. So this is usually something where we send patients to Princess Margaret, Sunnybrook, etc., and then they are there's various criteria, and you decide whether or not you're a candidate. So it's really different. Not everyone is a candidate for a trial. Not everyone needs a trial, but when you get to that point, usually you're referred somewhere, and then they decide, are you eligible or not? And then they decide what arm of the study you're on, etc. So that's sort of when your CLL becomes harder to treat generally. So a summary of treatment then is generally it's watch and wait when you first get diagnosed, provided that you're asymptomatic, you don't have symptoms. And then as hematologists, we always check your genetics. So as I mentioned, if you have that 17p deletion, or if you have that antibody mutation, IGHV, then you probably will be good to be on ibrutinib, generally, the general rule. If not, then let's say, so we still try to get you ibrutinib if possible. There are ways we can apply to the government, try to get access to it, etc. But if not, then if you're going to be on chemotherapy, and if that was deemed to be the best option for you, then we have to determine whether you're fit enough for chemo or not. So if you're really fit for chemo, then FCR may be an option.
So if you fail FCR,
yeah,
by default, are you not eligible for it?
If you fail FC, yes. So that's relapse. So this is like someone who's like first line coming in with CLL and they haven't had any treatment before. So these people, if you have the 17p or the IGHV, you can get ibrutinib right off the bat. You don't even need to be on FCR. You just go straight to ibrutinib. And so if you decide to go on chemo, then we're thinking FCR, chlorambucil, obinutuzumab, that kind of thing. Then you decide based on how fit you are. But yes, if you got chemo and then you relapsed, then generally you go on ibrutinib. And usually it's not a problem to get it, but again, it depends on each person. But whether you get ibrutinib right off the bat depends on these things. All right, and so next we'll talk about some complications. So that was sort of an overview of the treatment, but now, so let's say you have CLL, you're on or not on treatment. Things can happen that complicates the picture. So we talked about you having symptoms, the lymphocytes doubling, all of that, but you may also get other issues that are different but still a CLL issue. So there's something called hemolysis, which is basically where your red blood cells are destroyed. And the CLL can do that. So CLL can produce antibodies that destroy your red blood cells. It's kind of an immune, like your own body attacking itself. And we call this autoimmune hemolysis, and it can be a consequence of CLL. And so you might notice your hemoglobin starts going really low or dropping really low. And then the treatment for that is steroids. So we often treat it with steroid pills, and it tends to get better. You don't always have to treat the CLL when that happens. You can just treat the hemolysis with steroids, and then you can call it a day. If it doesn't get better, then you might think about treating the CLL with chemo or ibrutinib or whatever it might be. But that's a specific complication you treat in itself. Similarly, just like how your red blood cells are destroyed, your platelets could be destroyed too in a similar mechanism. And same thing, you treat that with steroids and watch, and if it doesn't get better, you might actually treat the CLL. Infections are a big thing. So as I mentioned, when you're on chemo, you can get infections because of low blood counts, but you can get infections even just having CLL. And the reason is that some people, when you have CLL, you can produce less antibodies than usual. So immunoglobulins are things that fight infections in your body. And in CLL, people tend to have lower levels of them. So your immune system is not as good, ultimately. So you're more prone to infection. So if you have CLL and you're getting a lot of infections, and not just colds, but like pneumonias and a lot of severe infections, then that might be why. It's because you have CLL and your immune system is not as good. And sometimes what we do for those people is, other than antibiotics to treat it, we give them the antibodies back. Like we give it through the IV. It's called IVIG, and it's basically giving you antibodies in your IV. It's like a soup of antibodies that we give to you, and it makes your immune system stronger. Another thing is becoming more aggressive. So we talked about this earlier. So your CLL has a risk of turning into something more aggressive. It's rare, but in some people, the CLL turns into a more aggressive lymphoma called diffuse large B-cell lymphoma. Exactly, yes. So basically, it's called a Richter's transformation, and it's basically where you're all of a sudden, so let's say you're sort of moving along and your CLL is great, and then all of a sudden one day you wake up or maybe not overnight, but over some days or weeks, you wake up and your lymph nodes are really big, swollen, you're losing weight. It's just a dramatic difference. It could just be the CLL getting worse, but it could also be now the CLL has turned into this more aggressive lymphoma called diffuse large B-cell lymphoma, or a Richter's transformation. And when that happens, the first thing that your hematologist might do is get a biopsy of something, lymph node, bone marrow, whatever it might be, to prove that this is not just CLL anymore, we're now dealing with something more. And when that happens, then you're going to get chemotherapy, because in that case, just ibrutinib probably wouldn't work, because now you have another more aggressive lymphoma. So you get chemo and maybe even a bone marrow transplant. So that's another possibility. It's rare, so it's not something we expect, but in some patients who have like a sudden like taking off of their disease, we worry about that. And generally, complications of treatment. So everything I mentioned so far are complications of the CLL, but you can also get complications of treatment, like being on ibrutinib with the AFib and all of that. And for example, chemo giving you infections. So those we treat accordingly. So basically what I mean is, when you have an infection, you get antibiotics. When you have AFib, you treat the AFib. So that's all treated accordingly. And you might want to adjust the dosing. So maybe reduce the dose of ibrutinib or reduce the chemo dose, etc., if it's causing complications. And then when you're treating someone, you always have to check for a response. So your hematologist probably sees you every few months when you're on ibrutinib, or when you're on chemo, maybe monthly, and they check things. So they check your blood counts to make sure they're good, because we don't want them to be going too low or too high. They want to make sure you're not feeling worse, and they monitor just generally to see how things are going. And the main thing is that whatever the reason they started treating you for, we want that to go away. So if your lymphocyte count doubled, say it was 30 and it went up to 100, and we started treating you, then we want to see it come back closer to 30 if possible. If we're treating you because you had really big lymph nodes and losing a ton of weight and all of this, then we want to see that you're gaining weight again and your lymph nodes are better again. So whatever the reason we're treating you for, we want that to get better, and hence we monitor that. The other thing I just remembered for ibrutinib to mention is that often when you first start on ibrutinib, your lymphocyte count may go up initially, actually. And people get scared because they think they're getting worse, but really it's just this flare that you get. So if your lymphocyte count is, let's say, 60, and you go on ibrutinib, and then all of a sudden you see your doctor and it's 120, it's doubled. That doesn't mean you're worse. It's the ibrutinib does that initially, and then the next time you see them, it'll probably be back down again. It's just the initial flare, and it's fine. All right, so drug coverage is a big thing, and unfortunately we would like to give you all these medications, but they're not always covered, and they're not always easy to access, and they're expensive. So generally ibrutinib is covered if you have those genetic issues I mentioned, and if you failed chemotherapy, then usually they would cover it. If you can't use ibrutinib, then idelalisib might be an option, which is the other one I mentioned, or venetoclax could be an option. And so generally our hospitals have a drug access coordinator who deals with these issues, because we don't always know what's covered and what isn't, and it's always changing and there's ways around it. So the drug coordinator will usually talk to you when you're in the cancer clinic and say, okay, do you have any private insurance? You know, where are you at? And then they'll decide what's covered and what isn't generally. And then they'll sort of tell us about it, and then we apply accordingly. So the general rule is that ibrutinib, if you have those genetic issues, or if you fail chemo, and then if you fail ibrutinib or you can't do ibrutinib, then maybe venetoclax or idelalisib generally, in an ideal world, and everyone's different though. All right. So treatments that are up and coming, I think you talked about this briefly, but there's a drug called acalabrutinib, still in clinical trials are going on, but it seems very promising. So Revlimid is a medication that often is used for myeloma, but there is some data or some research going on with that too. More venetoclax. So venetoclax is being trialed in different diseases now too, like AML or leukemia, acute myeloid leukemia. It's being used, and in many other myeloma, multiple myeloma. So there's a lot of trials with those. And then combinations. So people are trying to now put things together like venetoclax and rituximab, or ibrutinib and rituximab. So combinations of drugs in hopes that it will maybe be a bit better to kill the CLL than just one. All right, and then I just put a list of some supports here. So generally when you go to the hospital and you see your hematologist, there's a lot of info and a lot of things to remember, but we have a lot of people that work through different aspects of it. So the drug coordinators are really useful because they help with drug access. Your hematologist, of course, but also the general cancer care team. There's a CLL society as well that I think you can Google them, and they have a lot of resources. And then, of course, the Leukemia Lymphoma Society that you're here for today. So there are a lot of resources to help. All right, so we come back to the questions. So I think most of you already knew. So hormone therapy generally wouldn't be, so that we usually use in things like, your oncologist in something like breast cancer, they use hormone therapy because they target certain hormones. CLL generally, so chemotherapy we talked about, like FCR, bone marrow transplant, it's an option but rare. Immunotherapy is part of chemo, like rituximab, and then biologics are your targeted therapies like venetoclax, idelalisib, ibrutinib, etc. And then this one also was quite easy, I think. So ibrutinib we talked about. Imatinib is Gleevec, is used for CML, chronic myeloid leukemia. Revlimid, so it's used mostly in myeloma, as we talked about. And then chlorambucil, like someone pointed out correctly, it's a type of chemotherapy, so not generally considered like a targeted biologic therapy for CLL, which is a side effect of ibrutinib. You said all of the above. So it does cause this irregular heart rhythm or atrial fibrillation. It can cause bleeding because of the platelets not working as well. And also to note that your platelets may actually be normal in number. So platelets are 150 or above normal, and your platelets might be 200, but you might still have bleeding. But that's because the ibrutinib can affect the platelets and not affect their number, just their quality. So that's something to be aware of. And then nausea and vomiting, as with most medications. All right. Thank you.